Welcome to AETCM, the Emergency Medicine channel. Myself, Dr. Naveen Mohan, HOD of Emergency Medicine at AIMS Kochi.
I am Dr. Evan, first year ER resident.
I'm Dr. Jarin, final year resident.
I'm Dr. Cecil, first year ER resident.
Dr. Shreya, first year.
Sir, shall we start, sir?
Yes.
So today we are going to present a case of a 51-year-old male who was brought to our ER with alleged history of an RTA. It was a bike versus bike RTA, and following the RTA he was brought within 30 minutes of the accident.
Bike versus?
Bike. So on initial assessment, the patient was brought in a trolley.
You can just carefully hear what he's saying. Just after that, and at the end of this presentation, we can say like what all things are missing. Okay, just closely. All right.
So patient was brought in a trolley, conscious but restless, sir. So coming to the primary survey, here airway with C-spine protection. He was actually speaking some words, and so for the say at that point we were thinking, as the primary survey is doing at a multi-parameter approach, we will be having ABCD at same time. But for the case presentation wise, I will be speaking airway, breathing, circulation, disability. So in airway with C-spine protection, here the airway is patent with, and as patient was restless, we applied a C collar there, sir. And in the breathing part, with the ventilation, air entry was bilaterally equal with the respiratory rate of 18 per minute and saturation of 100% maintained in the room air. In circulation, with hemorrhage control, here the BP was 158/80 mmHg with pulse rate of 106 per minute, and all peripheral pulses were palpable. His mean arterial pressure was 106 mmHg, and there was left ear bleed, sir. In disability wise, his GCS score was E2 V2 M5 with pupil 2.5 mm bilaterally sluggish reactive. And in exposure wise, exposure was done, and initial exposure wise, there was no external obvious injuries noted. Further evaluation and further detail examination detail can be discussed here itself or in the secondary survey, sir.
Now, what do you think at the end of your primary survey?
Patient is restless.
What all things?
With the ear bleed noted, sir. That is the initial thing. Patient restless with the ear bleed and low GCS. So patient can go into worsening of GCS, and patient need intubation, sir. Rapid sequence intubation needed.
So what all things are like? Do you think? What's the problem? Did you understand?
In airway, we can initially check for with inspection. We can see for any local, any foreign bodies or any secretions, anything is there, or any gurgling sounds we are hearing or not. And the other one is the breathing part, inspection, palpation, percussion, auscultation. We can see. So inspection wise, we can see for the air, the chest movements, if it is bilaterally equal or one side it is reduced or not.
You already told, no? Bilaterally
equal auscultation. And this and the palpation.
Any problem?
Tenderness. Check for tenderness.
Sir, airway, actually he's talking some words, so we can consider it as patent. And due to low GSS, here already applied C collar. C-spine is protected from outside. And there is no, only ear bleed is there from a primary survey. No other bleed, and BP is also stable.
What is the age? 57.
51, sir.
51. What do you think? Any issue? 50?
51.
51.
51.
Alleged history of
RTA, sir.
RTA?
Bike versus bike.
Bike versus bike. Brought to ER by?
Brought to ER in an brought in here in an ambulance.
Ambulance. Okay. So you should be ready. First of all, you should be like whenever trauma case comes, you should be ready with your team.
Sir, the reading part we can divide like.
And that too, your presentation, it should be in a it's not going in a smooth fashion. It's almost like a stuttering kind of thing. It's not a confident way of presentation. So 51-year-old male, alleged history of RTA, bike versus bike, was brought in an ambulance to the ER. So before that itself, you should be ready with your team, assign roles. Got it? No? Because you are expecting a polytrauma. The ambulance team would have informed you prior that so and so case is coming with so and so problem. Without any gadgets or anything, you can't do anything. So how are you going to prepare?
Sir, for this case, we were not informed about case being coming. But in cases, if we are informed,
if in an ideal situation, you should be informed that such a case is coming from the pre-hospital. The paramedics should inform you that so and so accident has happened. We are bringing this case, and what is the present situation of the patient? What are the injuries? What are the vital signs? You should be hearing, you should be getting all things before arrival itself. So you will get an idea what to do.
Yes.
It's not like all of a sudden coming inside. It's not a systematic way of approach. Suppose in ideal situation, if you suppose it's a 50-year-old.
So in ideal situation, in pre-hospital itself, management will start, sir. In pre-hospital,
that is done by the paramedics.
Airway, control of bleeding,
okay.
Then transportation.
Suppose imagine 50-year-old male, bike versus bike, dealt by the paramedics. He brought in a ambulance. He has got bleeding on his head. He is drowsy and brought to the ER. So how you are going to approach? So systematic, step by step, you can say what you are going to do.
For in hospital, we should be ready for the same, sir. If we are getting an information, and we should have the required equipments should be ready. We should have adequate planning, and there should be a code alert also, sir. In cases of multi polytrauma cases and all, a code alert can also be made ready, sir. And
so the ambulance team has come with I'm the ambulance team. The doctor, this is the patient.
So we have
patient is drowsy.
Patient
has
is
got
drowsy.
bleeding from the head, and I have applied some gauze. So 50-year-old. So what are you going to ask?
So in initial survey.
Before that, how will you prepare yourself?
So for preparing yourself, we should be having personal
wear PP.
Then
gloves, everything. Okay.
Then we should be introducing. As such, if we are going to the ambulance drivers and all, we should be introducing them to them as
before that.
doctors.
Before that itself, you should be ready with the. Suppose she is a nurse, with all the nurses.
We should have a team, sir.
You should have a team assigned the roles. You take care of the airway, and take care of the airway equipments. Whatever, arrange all airway equipments. Then you take care of the circulation, airway and breathing. You take care. Breathing part, you take care, and circulation. And all circulation equipments, you get it arranged. Inform the trauma team that such a case is coming before arrival itself, because you already know it's a polytrauma. Okay, then inform the blood bank. The patient is profusely bleeding. Suppose he is in hypotension, drowsy. You are expecting massive bleeding. Inform the blood bank that we may need blood. Usually, if blood. What group?
Sir, blood group was initially arrangement. O negative can be arranged.
O negative, 2 units of O negative, you arrange. Then you'll also require a X-ray. You'll have to, from the start itself, you should be ready, telling all people you be ready with the X-ray, the trauma team, assign roles, and then you make sure that all your colleagues are ATLS trained. Okay. Make sure that everything is clear. So patient is arrived. So what you do?
So upon arrival,
this is the patient.
Upon arrival, a patient is the scenario patient is having low GCS with bleeding from head, sir. That's
Just assess from airway. How you are going to assess? Suppose this is the patient. How you are going to assess?
so head to toe examination is needed, but that
Head to
deep
toe is in the
examination
secondary
in
survey.
secondary survey, sir. Here we will be having initial 10-second survey, and we will be looking.
You forget that. You just do the primary survey.
Primary survey. Primary survey will be from airway part itself. We will be starting our survey, sir. And inspection, we will check for any abnormal.
I'm the examiner. I'll tell you. Just ask me what the relevant questions.
Sir, how's the inspection? How's the airway as such? Any abnormalities in the?
Before that, you do a manual inline stabilization. This is a trauma case, so do a manual inline stabilization. Okay. Then
After manual inhalation, C-collar should be applied, sir.
no. Is the airway patent? Second question is the airway patent? So I'm telling there is pooling of secretions.
Suction should be
And
done.
blood
sir.
is there. Blood is there. The oral cavity. Okay. So
Suction should be done. Pooling of secretion. Blood is there.
suction. You did suction. Please do suction. Suction done. Okay, done.
Then on inspection, any other obvious abnormalities noted or any how's the jaw is there? Then any neck also.
This patient had nothing, right?
Nothing.
Okay. Inspection wise, there are no foreign bodies, no swollen tongue, no other issues.
No other issues. Then any mal dissociation between the.
No issues. No structural problem in the face.
Then eye ear. That can be done in secondary survey also, sir.
That should be done in the secondary survey. Because in primary survey, you are basically what are you looking for?
Any obvious life-threatening injuries.
Any airway obstruction, any tracheobronchial injury. That is what you are basically looking for. You want to know whether the airway is patent or not. Got it, no? Okay.
Then
So you did a manual inline stabilization. Is the airway patent?
airway patent.
Blood is there.
Suction.
Please do suction. Suction done. Now?
Then will also inspection of neck also to look for any tracheobronchial injury can be done, sir.
Nothing is there.
Then
No tracheobronchial injury.
after inspection, then we'll go with the palpation, sir.
But you haven't assessed this thing. Once you do an intervention, did suction. You did the intervention. Reassess. Is the airway still patent? Is it
Airway
patent?
patent.
Is it patent? Is it patent? Huh? Patent. Okay. How do you assess patency?
If the patient is vocalizing, if he's saying his name, if he's able to complete full sentence.
Suppose this patient is not vocalizing. No?
Listen for any
Wait.
gurgling sound.
Okay. No gurgling sound. Airway is not patent. So what is your next step?
Rapid sequence intubation should be done, sir.
No.
That is C-spine protection has to be C-collar has to
Manual inline stabilization you have done. Airway is not patent despite suctioning. Now
be C-collar has to be applied, and then
that is the next step. Your inline stabilization is already done.
then we can go with jaw thrust and
Put an oropharyngeal airway. OPA. Got it?
Sir, we can directly go for intubation, no, sir.
No,
RS.
that is step by step. That you can go straight away. But when we talk from a theoretical aspect, you put a oropharyngeal airway. Suppose the patient is gagging. What will you do?
Oropharyngeal airway can cause gagging, sir. When we put
can't
it.
keep. We have to go for that.
Gagging. So gag reflex is present. For this patient, I am telling, patient doesn't have a gag reflex.
That
You
means
placed the oropharyngeal airway, patient, and
that is a threatened airway, sir.
but now you place a OPA, but now airway is patent.
Mm.
So what are you going to do?
Once as the patient is we are suspecting a threatened airway and we are having a manual inlay stabilization, we have to palpate for any expand tenderness as such is there, or then C-collar is put, then rapid sequence intubation, sir.
No. Inline stabilization is already there. So no need to put C-collar at that point. We have already done an inline stabilization. Once the patient is tolerating an OPA, that means it's an airway is compromised. Anyway, you'll have to do definitive
Definitely.
intubation. Definitive airway has to be placed. Intubation has to be done. Got it, no? Okay, so after that, you prepare your intubation things and all, and then you intubate. Because patient is tolerating OPA. So take out the OPA, you intubate. After intubation, what drug will you use for suspected head injury case? What all drugs?
Use like etomidate can be done, used for induction, sir, and for skeletal muscle paralysis you can use rocuronium also, sir, or scoline.
Short
also
acting.
can be.
Okay, paralytic agent. Okay.
Rather
So
than
you intubate.
propofol or
So you intubate. Now what? So you have intubated this case. Now.
So here the main thing about intubation also, we had to look for any base of skull fracture. We won't be knowing, but we had to look for any upper in the oral airway, any abnormalities. Is there any bleeding from the base of?
What does it? What is the significance?
Sir, any
You have already intubated. No,
no, before
tube is
intubation,
inside,
sir.
right?
Before intubation, I told. After intubation,
Now tube is inside. You have secured it. Once you intubated, now what?
after intubation,
Airways patent. Airways patent.
Protect the C-spine C-collar. C-collar should be applied.
Okay, you tell me.
C-collar manual inlet stabilization should be changed with C-collar, sir.
Okay. Okay. Now
One after
you applied the C collar. Okay, C collar applied. Now
then reassess the patient, sir.
reassessing for
Reassessing for how's the
airway still patent.
still patent, sir. Then after we will go with the breathing part, sir. In the breathing part, we will have initial inspection.
No tracheobronchial injuries, airway.
Neck was okay, sir. No tracheal deviation or no tracheobronchial injuries.
Inspection wise, airway is patent. Now moving to B.
B. Neck inspection, there is no obvious abnormality. Trachea central. Then on
no visible other injuries.
No visible other injuries. In chest, we could see some little contusion over the left clavicular region, sir.
Left clavicle contusion. Inspection wise.
Inspection. Then
so what all things you are going to look for inspection?
Any abnormal chest movements, any open chest injury, any sucking chest wound, any
Reduced chest movements.
Reduced chest movements,
Dilated neck veins.
Neck veins, any abrasion, penetrations,
Decap, BTLS, I've already told you.
Deformity,
discoloration, deformity, contusion, abrasion, puncture, penetration, bleeding, tenderness, laceration, swelling. It covers almost everything, I think so. Okay. So you saw a contusion here on the left clavicular area. Okay. Now,
so in this patient,
that's the inspection. Palpation.
Palpation, we had to palpate the chest, sir, and had to look for
palpation. There is tenderness. Here,
breast.
I'm telling you, there is tenderness. What next?
We'll
Percussion.
Percussion we had to do.
Percussion is normal.
Auscultation also should be done to rule out any pneumothorax. Air entry should be noted, sir.
Respiratory rate is 7 per minute.
The reduced respiratory rate is our intubated patient respiratory?
Patient is intubated.
Then
respiratory rate is 7 per minute. You only intubated, right? You only intubated. Now respiratory rate is 7.
Sir, if any tube block or something.
Airways patent. What is the problem?
Change the setting, sir.
Setting? But you didn't do anything. You just intubated, right?
Ventilator settings.
But you didn't connect it to ventilator.
We can connect to ventilator, sir.
You just intubated. Tube is there. You didn't even do ambu bagging.
Okay, sir.
So that's why the respiratory rate is 7.
Okay, sir.
Got it, no? Clear, right?
Okay, sir.
He just intubated. The whatever breath he is taking, that's his own breath. Once you do ambu bagging only, it will... Okay. All right. So now you did ambu bagging. What rate would you set?
Every 6 seconds we will give one breath, sir.
What rate?
Every
Normal rate is
No.
normal respiratory rate. 12 to 20, right? 12 to 20. No, between 12 to 20 you can set.
Okay.
12 breaths or something you can set. Okay. Now there is chest rise.
Mm.
Auscultation wise, air and breath bilaterally equal. Okay. So in breathing, you're addressing what all things?
Breathing
Pneumothorax. Open pneumothorax and
tension
massive hemothorax.
Hemothorax.
Tension pneumothorax.
And also we can during that time itself we can look for cardiac tamponade, muffled heart zones also can be assessed.
That can be checked, but it's better you do it in seeds. See. Now B is clear. Now.
Then and coming to the circulation part, circulation also will be initially inspection. We'll be looking for dilated neck veins in the part. Then we'll be having any
dilated neck veins for cardiac tamponade. That is already checked, right? In the neck, you already inspection is already over. Now see.
Then we will look for any any external injury. Circulation should be circulation, breathing and circulation. But
heart rate, BP, CRT.
CRT.
3 questions. Okay. Heart rate is 120 per minute. BP is 80, 60. CRT is 5 seconds. Now.
That is, the patient is in hemorrhagic shock, sir.
Hemorrhagic, you don't know. You haven't ruled out other things. There are different. Hypertension can be because of several things. Most common cause of this thing is trauma. Hemorrhagic shock. In the case of trauma, that is the most common cause. Okay. So what to do now? This is the condition. Heart rate is 120, BP is 80, 60. CRT is 5 seconds, or else say 7 seconds. Now.
If we had to find the source of the cause for the shock itself, sir, initially, so we can, if an external examination, if we are able to find any cause for the shock, that is any external
bleeding.
bleeding.
You don't have time, no? It's a primary survey going on. Primary survey. What next?
IV fluid.
You have to act.
IV fluid 1 liter.
You haven't placed IV line.
IV line can be put, sir.
Place. Can it's not can be. You should place.
Too large.
This is the condition, no? Okay.
Too large bore IV cannula can be put, sir.
You place.
Yes.
Placed. Too large bore IV cannula placed. Now.
Then we can give for adult patient 1 liter fluid bolus can be given, sir.
1 liter fluid bolus. But before that, you would like to draw blood samples, right?
Yes, sir. 2 large bore IV cannula, 1 cannula can be used for blood sample, other can be.
But you should give orders, no?
Yes,
suppose I'm the nurse here. You should give orders. What all things to use. What?
Sir, we can initially look for CBC,
hematology, biochemistry, blood
CBC,
culture, blood
RRT,
gases,
sodium, potassium, blood gas, VBG also can be.
Okay, sir. Already everything is taken.
Yes, sir.
Now, fluid bolus you gave.
Yes, sir.
Okay, how much fluid bolus?
1 liter.
Of what?
RL or NS can be given, sir.
Okay, simple or plain or warm NS?
Warm. In case of trauma, it is better to have a warm fluid, sir.
Okay. Fluid. 1 pint of warm normal saline started. Now?
Yes, sir. We will have to reassess how the.
You are in
BP,
C, right? You are in C.
C.
Finish C.
No, sir. We have to reassess how his BP is picking up or not, sir.
It's slowly picking up.
Then we'll go into disability part.
No, it's not over. It's not over.
We have to arrange for.
You arrange blood, no?
Arrange our blood.
Blood samples. Just ask, confirm whether blood is O negative blood is. You have already in the arrival itself. You have told them. Please confirm whether O negative blood is arrived or not. No, it's still on the way. ABG has come. ABG HB is 10.
HB is on the lower side, sir. But as such, from the new ATLS criteria, HP more than or equal to 10 is
10.
That should be maintained, sir. 7, sir. 7. More than 7 should be maintained.
That's okay. Now what? Continue circulation, assessment and circulation.
Then had to look for warm peripheral pulses palpable. Then
Peripheral pulses are, but peripheries are a bit cold, clammy.
cold, clammy, or impending
Palpable, it's
shocks.
palpable.
Then about base deficits.
Complete the C, no?
Then, sir, patient was having left ear bleed.
Left ear bleed will not cause this much of a hypotension, hemorrhagic shock.
Check for any external source of bleeding that I already gave bonus. So check for an external bleeding also. Then we can give Tranexa. So
Check for any external source of bleeding and then
Tranexa injection.
yeah, Tranexa you can give in that point.
1 gram IV over 10 minutes can be given, sir.
Okay, if you're suspecting a
Bleed, sir.
hemorrhagic shock.
Hemorrhagic shock.
Okay.
And then you can do a fast examination.
But before completing fast examination, you'll have to finish your inspection, palpation, these things. You are still in C. You have checked heart rate, BP, CRT, placed the IV cannula, drawn blood samples for hematology, biochemistry, over all these things, and then you have started warm NS 1 liter. Now,
Sir,
where all you are expecting a bleed? Major areas in the body.
cases of RTA, we can expect a bleeding, long bone fracture bleed can be there. Then any abdomen, intra-abdominal, any.
Yeah, that you'll have to say, no?
Yes.
So abdomen examination has to be done,
Patient is sedated.
right? No.
Okay, sir. Abdomen was.
Chest part, major bleeding points are in the chest. Massive hemothorax, these kind of things in the abdomen, pelvis, long bones, and then some blood on the floor. If it is a massive thing, means there will be blood on the floor. So just inspect, do the inspection.
Inspection wise, no obvious abnormality noted, sir.
On the abdomen, no obvious. Chest is already clear because breathing part he has already finished, and that part is clear. So he's not clinically suspecting any
Blood loss.
any chest hemothorax. Suppose you are able to do X-ray in B itself. I'm telling X-ray is normal
Then
because you have already arranged, already informed the X-ray guys that the guy. So on arrival itself, suppose the patient is placed on that X-ray plate. You press the button and you got the X-ray. Chest X-ray is clear. Okay. Then abdomen.
Abdomen after inspection.
No tenderness, guarding rigidity. No inspection wise, no obvious injuries.
Then
No palpation, no tenderness, guarding or rigidity. If there is tenderness, guarding or rigidity, what does it mean? Hemoperitoneum, right? Bleeding. Okay, so I'm telling you, there is no tenderness, guarding or rigidity.
new hemoperitoneum, no bleeding from the abdomen.
Okay.
Then we have to look for extremities for any bleeding sites. Long bones are the other side. Pelvis and long bones are the other sides.
Pelvis.
Urethral.
There is pelvic instability. I'm telling you.
We have to have pelvic strap. Have to put in, sir.
Yeah, pelvic binder applied. Right. Now?
Now urethral, we have to look for any urethral tip of urethra. Any bleeding is there.
Then no bleed.
No bleed. As such, for the new ATLS guidelines, palpation of prostate is removed.
This is not relevant in this scenario. No need to tell these things because in this scenario these are not. Because I already told you there is no bleed. Okay. Now long bones.
Long bones, sir. Long bones had to look for had to inspection if any abnormalities.
Long bones are clear. No fractures. No amputation. Okay. Now.
Then disability, sir.
You have to also
Blood has come.
since there's a pelvic injury, you'll have to keep permissive hypotension as well. So we should not rush in fluids to keep BP more than 90-60. Around 80-50 is also permissible.
Okay.
So we have to reassess how's the BP picking up after
Suppose-
the IV fluid.
okay.
And if BP is not picking up, if blood came, we can give
blood came.
blood, sir.
What you want to give?
one is sir, for massive transfusion we can give one is
O negative, no? O negative came.
O negative blood can be given, sir.
You give, no?
Okay.
So two units you gave. Okay. Now
Then we will assess the disability parts.
blood grouping cross matching.
That we have to send initial.
Okay, so we'll wait for that.
Circulation itself we will
Okay.
send for a blood
Now
grouping.
the C part has improved. Now BP's
Picking.
come up to became 110 70. Heart rate is 80. CRTs 1 second. Okay, now
So BP has been picked up on reassessment.
so you have dealt with the circulation.
Circulation.
Okay,
We'll move
now
on
more
to disability part, sir. In disability, here else we'll initially assess for the GCS part, sir. GCS for this patient,
What is the GRBS?
GRBS of the patient was 91, sir.
Okay, normal, right? Okay, now GCS
GCS E2, V2, M5.
E2 V2 M5. But you have paralyzed him with rocuronium, right?
Sir, this is normal case.
All right, okay. All right. E2 V2 M5. No?
So, this patient
Pupils?
was 2.5 ml bilateral Sagnish reactive.
Any lateralizing signs?
No, sir.
So only problem in disability is
GCS low.
GCS drop. So
Dropping
you are
it.
suspecting
Head injury, traumatic brain injury.
okay. GCS how much?
E2, V2, M5.
So the total will be score will be 9. So you are just suspecting like severe or mild or moderate head injury.
Sir, less than 9 is severe.
What is the classification of
So,
this thing?
initially it was like a minor in all.
What is the current
Current
classification?
is mild, moderate, severe. 14, 15 is mild. 13 to 9 is moderate.
Mild head injury,
Moderate. Mild head injury is 14 to 15 GCS.
traumatic brain injury, TBI, right?
TBI.
Severe TBI, moderate TBI, and
Mild.
TBI. Okay.
Mild is GCS of 14 to 15, sir. Then the 13 to 9 to 13 is moderate. Less than 9 is severe, sir.
So this is?
This is 9, sir. 9, but patient, according to the new ATLS guidelines, patient having low GCS with restlessness, in this scenario, with the GCS of this and patient being restless, we intubated here, sir.
Any idea about the new Glasgow Coma Scale?
Yes, sir.
The new latest ATLS? Any idea?
Yes, sir.
What is the new guideline? New Glasgow Coma Scale.
New Glasgow Coma Scale, non-testable is the new one, sir.
What other things? Any idea? Say. New Glasgow Coma Scale. ATLS book it is there.
Yes.
And just go through. What is it? Just tell me.
Sir, in eye opening, spontaneous will be E1, 2 sound is V2. So, spontaneous will be E4, sir. Spontaneous E4. Then 2 sound is E3. 2 pressure is E2. None will be E1. Then there is non-testable condition, sir. That is END. Then in verbal response also it is like the same. V5 will be oriented. V4 will be confused. V3 will be words. V2 will be sounds. V1 will be none. And then there is non-testable will be VND. And in cases of motor response, it's changed to best motor response where M6 will be obeying command, M5 will be localizing, M4 will be normal flexion, M3 will be abnormal flexion, M2 up extension, and M1 none. Then non-testable MND. So,
This is one of the reason in ATLS updates. Pertaining to head trauma, this can be a question. The new Glasgow Coma Scale. Other recent advances in head trauma will be the thing is initially we said C-spine protection. Now it has been changed to restriction of spinal movement. The term has been changed. Okay. Then what else is there in head trauma? We'll move on. Yeah. So GCS is this much. Okay. Already intubated.
Sir. Then in exposure wise, we'll have to look for as such, we had done the whole thing. Then
So at this point, you're suspecting a head injury. Should we do you want to start on any 3% saline or mannitol or anything?
after the imaging, we can start, sir.
Okay.
So we have covered the patient to prevent hypothermia, sir, in exposure part.
No other evident injuries.
No.
You exposed completely. No other
Exposed
issues.
completely. No other evident injuries.
The log rolling. When are you planning to do?
Log rolling can be done in secondary survey or head secondary survey.
Primary itself you can do, no?
Or else when we are shifting the patient from ambulance
Exposure itself we can do it. Exposure. Because suppose there was some problem in C which you couldn't find out. Okay, then you should be doing a log roll at that point is to see if there is something wrong on the posterior aspect of the body, some injuries, and then you should have controlled that part. There is some stab wound from the posterior aspect, you should have controlled at that point itself. Suppose that C part is clear, you have moved to D and then come to E. Now you are doing exposure. Exposure means you can expose the entire body including front as well as back. At that point you can do a log rolling. So I'm telling E is clear.
Sir, one doubt, sir. Can we do the log rolling in initial stage when we are shifting the patient from ambulance to the...
That is also possible. But for exam purpose, I think this is better. Because anyway, you'll be once you shift, you'll be log rolling and taking inside. At that point itself, quickly you can finish it off. But for exam purpose, if you are attending an OSCE exam or anything on clinical examination, this is the sequence that you'll have to.
Yes, sir.
Oh, okay.
Then, as this patient was having a severe, intubated severe brain
So
injury,
the trauma, pardon?
we did the E-fast, sir.
E-fast.
E-fast was done, sir.
E-fast should have been done in C itself.
Circulation.
C itself. Because patient had a this thing, unstable pelvis, for which you applied pelvic binder.
Sir, this patient, other patient had, but this patient never had.
This patient never had. Okay.
E-fast
So this
was
patient didn't
negative.
have a what? Is there any indication for E-fast in this case?
But this patient has GCS was on the lower side. Anyway, as bike versus high speed injury.
So E-fast ideally, because of the mechanism of injury you wanted to do. Theoretically, it's okay. So what was E-fast?
E-fast was negative, sir.
See, E-fast, what all things, which all views you are going to look at?
Right and left hypochondrium will look, hepatorenal, splenorenal. Then we'll look for cardiac. Then we'll look at pelvic region, bladder. We'll look. Then in E-fast, extended fast, we'll look for on the lungs to look for any pneumothorax or absent lung sliding signs, sir.
What are the signs there you're looking for?
Normally we will get a seashore sign, but absent lung sliding means the barcode sign we'll see.
Okay. So now patient you have completed your E. Okay. So there is delay, you have already informed the concerned specialty also, right?
Yes, sir.
Suspecting there is an injury, already told there is an injury on the head. So you're suspecting this thing. But they are taking more time. They are yet to come. So what is the next plan?
So our next plan will be
Reassess ABCD.
reassessing of the ABCD.
Now it is clear. ABCD is fine. Now.
Once ABCD is fine,
Sorry.
Once ABCD is fine, after reassessment we can continue further for further plan of action. As this patient was having a low GSS restlessness, we will be thinking in the way of that patient will be having a head injury or there is chance of IC bleed.
What is the ample history? Now the most secondary survey, no? Ample history.
So here the ample history, as such initially we are not able to get the total history of the patient because of
That's okay. Total history not available. Okay.
So the known history is the patient was a known case of type 2 diabetes, hypertension, dyslipidemia patient, and medications were not known, sir.
No allergies.
That also not known, sir.
Okay.
With the highlights history of an RTA, bike versus bike, further history was not known, sir. So the bystanders were telling that he had history of an LOC.
If it is a blunt injury in the abdomen, which organ is most likely to be affected? Blunt injury. The most common
Spleen.
injury is spleen. Penetrating injury. Not liver.
Liver.
Only liver only things.
Liver.
Gunshot injury. Bowel. Small bowel. Okay, so you don't know the history. Ideally, you should have taken the mechanism of injury, mechanism of injury and all. So you should have asked who saw it, where it happened, when it happened, what happened, at what time, what happened before the event, during the event, after the event, and what was done by the onlookers, what initial treatment was given, and whether the patient was conscious after the accident. At any point, patient was conscious or became conscious. Because we saw it GCS 7, right? 7,
GCS 9, sir. Initially,
we want to know whether the patient had some lucid interval or anything of that sort. Because the injuries you are expecting in head is SDH, EDH, and SH. IC bleed. Okay.
So from the known history that he had a history of an LOC, sir. History of an LOC was present, and we have noted that he has having a history of left ear bleed. And
left ear bleed, that should be. Initially, you can just keep a pack or something just to control bleeding, but that shouldn't cause a high hemorrhagic shock.
So, from the accident site, the patient was taken to a nearby hospital, and there he was given 1 gram injection levetiracetam was given, and following which patient was referred to our hospital for further management.
By levetiracetam? Through seizure.
To prevent seizure, I think.
So that itself can cause a drowsiness. Levetiracetam. Drug induced. It need not be necessarily because of the head trauma. Okay. Then?
So that's about.
You have already informed the orthopedics for the, if it is a pelvic fracture and all, you would have informed. Neurosurgery, I have already informed. They are yet to come.
Yet to come, sir.
Okay. No.
So we will further do the head-to-toe examination with CT brain, sir.
Head-to-toe examination, there is a laceration, and then on the here you did suturing.
Then CT brain was taken, sir.
Okay. What is
the CT brain was showing SDH right frontoparietal region.
CT brain, the C-spine should have
C-spine also taken, sir.
Okay.
C-spine was normal. This CT brain was showing SDH right frontoparietal region with the bilateral diffuse SH. Multiple patches are noted, sir.
Right. What is it?
Right frontoparietal SDH, sir.
SDH. Okay. SDH is caused by? What is the reason for SDH?
Tearing of the veins.
Veins, sir. Vein.
Tearing of the bridging veins.
Bridging veins.
Okay. EDH is caused by? Middle artery rupture.
Then
okay, this is SDH. Okay.
SDH and SH is also there, sir.
SH is caused by?
The vessels, sir. Parenchymal vessels.
How do you differentiate between SDH, EDH and SH in a CT?
So SH will be like a multiple suture line will be passed and concave.
It will be in the sulci area and all, and also the cisterns, SH. But whereas in EDH it will be biconvex shape, and SDH it will be concave convex shape.
So
EDH means it is where is it situated? Extradural.
Extradural. Yes,
but other things are inside.
Inside.
Okay. So this is SDH with SH.
SDH with SH.
All right. Now.
Then patient also had right frontal tissue hemorrhage, left parietotemporal hairline fracture, and left auditory canal fracture.
So okay. ENT is also called.
ENT was also called, sir.
Okay. How are you going to manage this?
So for management, the patient was having a restless behavior with low GCS. So we should keep the patient at a 30-degree head and elevation. 3 patients saline should be given. And also injection
How much should be given?
Sir, we have to
the basic. What is the underlying when you manage a head trauma? What is the underlying this thing concept? What are you planning to do there?
To reduce the edema, sir.
The secondary brain injury
should be reduced.
Has to be reduced, right? So what are the secondary brain injuries? Like how do you reduce the secondary brain injury?
We have to prevent hypothermia.
That is well.
Hyponormalizing.
Prevent?
You have to prevent hypoxia. You have to
What is
normoxia.
the target level?
Target level is 92 to 98%. Normoxia.
O2 saturation should be greater than 95%, sir.
What is the ATLS guideline?
ATLS greater than 95, saturation
95 or
95.
90?
95, sir. O2 saturation greater than 95. Yes, sir. PO2 should be greater than 15. Then
15.
15. Sir. Sir, sorry. ICP should be 5 to 15, sir. ICP get 5 to 15.
No, what, like in the airway, no, you have intubated. So what is your target?
Saturation should be greater than 95. 95.
Is it 95 or 90? You'll have to confirm whether it's 95 or 90. I remember it's more than 90 for this thing. ATLS. PO2, what is the target?
PO2 should be greater than 60, sir.
60. PO2 more than 60 in ABG. Okay, then?
ICP 5 to 15. With the cerebral perfusion pressure of greater than 60.
ICP 5 to 15. Around 10 you keep. Okay.
Cerebral perfusion pressure greater than 60.
What is the normal ICP?
ICP less than 20, sir.
Okay. So what is basically there is a concept called auto-regulation. Right. So what is that?
So if the BP is increasing, to counterreact the head in brain, there will be ICP.
The formula is, what is the formula?
MAP minus ICP. CPP is equal to MAP minus ICP.
Cerebral perfusion pressure is equal to?
MAP minus ICP.
MAP minus ICP. Okay. So what is this thing, cerebral perfusion pressure that you plan to keep?
So greater than 60, sir.
Greater than 60. Okay. Normal is between? CPP?
Normal is
between 50 to 150, that range. Your target is to keep it more than 60. Okay. What is the ICP?
Sir, ICP 5 to 15, sir.
What is the target? Around 10 you'll have to keep.
Between 5 to 15, sir.
Alright. So what is your target MAP that you're planning to keep?
60 to 70 MAP should be kept, sir. So
systolic BP, what is the target BP, systolic
this
BP?
Patient, sir, for according to guidelines, for 50 to 69-year-old people, the systolic BP should be more than 100. Whereas in more than 70 years of age and less than 50 years of age, you have to keep a BP of more than 110, sir.
Yeah. So just remember 50 to 69 systolic BP, keep it more than 110 or more. All the elderly above
69.
About 69 or
Less than 50.
Less than 50, you keep it at
110.
Or 100. 110. 110. The other one is 100. Okay. Then?
No, sir.
PCO2.
35 to 45.
PCO level should be 35 to 45.
pH 7.3 to 7.4.
pH?
7.35 to 7.45.
Okay. Then?
Normoglycemia.
Normoglycemia. What is the target sugar?
Like 80 to 180.
Okay. Then?
Normothermia.
Temperature?
Temperature 34 to 36 degree.
Or 36 to 38? 36 to 38 or 32 to
34 to 36.
34 to 36. What is it? What does it give? Okay, just check. Okay, then what? So you want to prevent what the primary injury has already happened. Head injury has already happened. Now in the ER, our priority is to prevent the secondary injuries which has resulted. Okay. Okay. So how are you going to treat?
So for preventing it, we had to give 3% saline with a like a cutoff, like maintaining a sodium value of 145, high upper level of sodium values. Then avoid any necklines, sir. Then you have to give 30 degree head and elevation should be given. And
Mannitol will you give?
mannitol in newer guidelines.
If there is hypotension, will you give?
No, sir.
If there is renal failure, will you give?
No, sir. More than mannitol, 3% saline.
What is the dose? What is the dose? Newer guidelines, you're talking about newer guidelines.
They are suggestive of using 3% saline rather than mannitol, sir.
Any indication for anti-epileptic drugs?
Anti-epileptic also, the guidelines, it is not so clearly defined, but better to give anti-epileptics to prevent any seizure.
Okay. Ideally, after this, you should have got a. You were unable to get a complete history, so that's why I didn't go into detail. Okay. Anything more?
Yes.
Anything which I missed?
Then nice guidelines for CT head, sir.
Nice guidelines for CT head is there because they have got shortage of CT the machines and all. They have kept a separate guideline like within 1 hour which all patients have to be CT. What is the indication for doing CT within 1 hour?
Sir, indication for seeing within 1 hour is GCS less than.
In ATLS we have got the New Orleans criteria as well as the Canadian CT head rule. Based on that, you decide whether to do CT or not. But in nice guidelines, you have got another criteria.
So
it's a combined, it's somewhat similar only, but they have within 1 hour what all. What is just
GCS less than 13, we have to go for CT. Then if GCS is less than 15 after 2 hours of injury, or if the patient is having an open or depressed skull fracture or base of skull fracture, any focal neurological deficit, seizure and vomiting more than 1 episode, we have to anyway go for a fracture. If the patient is having any anticoagulation therapy going on, we have to go for CT. Or else if the patient, in cases of a dangerous mechanism in age grade, if these things are negative, you have to look at other factors like if the patient is having an age greater than 65, history of bleeding disorders, dangerous mechanism, or amnesia greater than 30 minutes, we will go for CT, sir.
Okay.
That's it regarding.
So Canadian C-spine rule, is it applicable here?
Canadian
C-spine rule, is it? Can we apply this here?
Age greater than Canadian C-spine rule is like age greater than 65 with the dangerous mechanism of injury.
No. Is it applicable in this case? You already intubated this case.
Before in
whether the need for radiography is Canadian C-spine rule. That is applicable for conscious patients, alert patients, full GCS patients, not these kind of patients. Okay. This way anyway you'll have to do a CT. Okay. Done. Okay. Thank you.